Hello and welcome to Lung Cancer Connect. Delighted that we have our speaker this morning.
Hello, I'm Jakub Kadlec. I'm a thoracic consultant working in NHS hospital in Norwich.
So to start us off, can I ask you, can you explain a bit more about the tests that would be required to identify if a lung cancer is suitable for surgery?
So initially patients usually come with problems which leads to organization of a chest x-ray, and on the chest x-ray there is an abnormality which is found, and from that point we need to clarify what actually the abnormality is and how extensive the disease is if it is found to be lung cancer. So after chest x-ray, usually the next investigation is CT scan of the chest, which includes a bit of abdomen as well as neck. And there will be finding which will clarify if the patient is more suitable for surgical treatment or non-surgical treatments. And then we need to clarify, apart from findings in the chest, if there is any disease in different place than in chest only. So patients usually go for PET scan, which will show up if indeed the findings are only localized in the chest. And if it is, then we usually proceed with a biopsy, either by way of CT-guided biopsy or bronchoscopy, which will clarify if that finding which we found is indeed lung cancer or non-cancerous lesion. Some patients might also have a further imaging modalities like imaging of the head, but that's usually in the patients who have more advanced cancers, just to clarify that we indeed treat a patient who has only localized disease.
And if someone is told they need a bronchoscopy, how will that be done, and will it require a stay in a hospital?
So bronchoscopy is a treatment where the doctors are passing a flexible bronchoscope via mouth or nose into the airways via the glottis, and they try to find the lesion, to biopsy it, to clarify if indeed it is a cancer. It is usually the same procedure, so patients usually come and they go home in the same day. It's highly unlikely that they will have to stay in hospital overnight. And the procedure is not done in general anesthetics, but requires sedation. Sometimes they might find it a little bit uncomfortable and cough a little bit during the procedure, but it's only temporary. And once the bronchoscope is removed, that's all passed and the patients are feeling well. They usually have a bit of local anesthetics in their vocal cords, so they can't drink and eat for the approximately 1 hour after the procedure, but after that there are no limitations for what they can do. They might expect that if there is a biopsy, there might be a little bit of bleeding when they are coughing up, a little bit of phlegm, but it should be only minimal, and again it will cease within 1 or 2 days.
And in terms of for someone who is being considered for lung cancer surgery, if they have other health problems, will that affect how likely it is that they can have surgery?
So that's based on individual patients. Obviously, patients with no comorbidities are less risk for operations, but even patients with significant comorbidities can have surgery, but it all depends on individual circumstances, on a patient performance status, meaning how well they can mobilize or how much they do in normal activities during normal days. So people with comorbidities need to be assessed, and comorbidities as such don't preclude patient from surgery, but it depends on the overall assessment, not only comorbidities, but also advancement of the cancer, the wishes of the patient, and suitability for surgery as such.